After the vitals, we start with the hand, examine the hand, then the head, neck, trunk, and the legs. The examination of the hand includes the both its sides. On the palmar side, you ask the patient to extend the fingers. दोनों हाथ यूं सीधे करने हैं. Look at the hands. Look at the color. The color of the hand depends on the thickness of the skin of the hand. In the manual workers, it is usually thick and the color may not be very evident. But the abnormal things which you can see in the hand is, one is the palmar erythema, in which the thenar and the hypothenar eminence, they are pink and the center of the hand is pale. That is called the palmar erythema. Then if you ask the patient to extend the fingers, normally one will be able to do it. You do not see any abnormality. But in some cases, there may be a limitation of the extension, and on forceful extension, the palmar aponeurosis that fans out. This is called Dupuytren contracture. Then the tips of the fingers might be bluish, and if the fingers they are bluish, this will be called peripheral cyanosis. And then on the other side, you look on the nails of the patient. Normally the nails they are convex from side to side and straight in their long axis. Now there can be, you can see the different shapes of the nail. For example, this is what you see. The upper one is a normal nail, second one is also a normal variant, and the third one is clubbing, in which there is no angle between the nail and the nail bed. So the shape of the nail might be look different because of the clubbing, and to demonstrate the clubbing you need to see the nail, bring it at the level of your eyes and see if the angle between the nail and the nail bed is visible or not. If the angle between the nail and the nail bed is visible, then this is normal. And if there is no angle, there is a straight line, then it will be called clubbing. Now, how do you demonstrate the first degree of clubbing? You place your two thumbs under the finger, bring your both the index fingers on the nail bed, you press the nail on one side and you feel the movement of the nail with the other finger. If there is a this type of movement or the fluctuation is present, then this is the first degree clubbing. In the nail you can see also other abnormalities. In the nail you can come across the white lines. This is all physiological. The white lines present under the nail, they are usually physiological. The nail may be flat, which is called the platinichia, or it may be depressed like the shape of a spoon, and it is called the spoon-shaped nails. There might be the transverse ridge over the nails, which is commonly seen. It is called the Bewes line. It is commonly seen whenever there is a severe illness. The nail growth is retarded and a ridge appears under the nails. Then there might be pitting of the nail. Small pinhead depressions may be there, which you commonly see in patients with the psoriasis. So these are the common findings which you see under the nail. In the hand you also look for the whether the hand is warm or it is a cold and sweaty. Then whether the tremors are present or not. To demonstrate the fine tremors, you ask the patient to extend both the hands and make them stiff. Bring your eyes at the level of the hand and you look for any vibration. If the vibration is present, then you will say that the fine tremors are present. There might be coarse tremors present in the hands. And then third is the flapping tremors. You ask the patient to extend both the hands and extend at the wrist joint and look for this type of movement. This is called the flapping tremor. Under the nails you can find the splinter hemorrhages. The splinter hemorrhages, they can be present proximally close to the base of the nail or at the distal part of the nail. The splinter hemorrhages which are present at the distal end of the nail, they are usually traumatic, and the splinter hemorrhages which are close to the base of the nail, they are pathological.
If you have seen my last video, that was related to the general physical examination, and in that we talked about the vitals, and among the vitals lastly we were discussing the pulse, and in the pulse there was one thing which was left, and that is the pulsus paradoxus. How do we see the pulsus paradoxus, or how do we find it? The method is that when you place your fingers over the radial artery and you are taking the pulse, carefully look at the chest of the patient and concentrate on the respiratory cycle, and at the same time feel the pulse. And what you have to observe is that is there any decrease in the pulse volume at the end of the inspiration? If it is so, then this will be suspected pulsus paradoxus. And how do we demonstrate it? To demonstrate it, you will have to apply the cuff to the arm, inflate it above the systolic, and then slowly deflate it no more than 1 millimeter per second. Note the first crowd cough sound and also concentrate on the patient and see that this will be in the expiration. There will be no sound in the inspiration. You gradually lower it down till the number of sounds are doubled, meaning thereby it will be audible in the inspiration as well as in expiration. So when it is audible both in inspiration as well as expiration, the difference between the first sound and where the number of sounds doubled is called the paradox. If it is more than 10 millimeters, this will be considered abnormal. After the pulse, we proceed forward and we go to the face of the patient, and there are so many things which you can see, there are so many findings. But in the general physical examination, you have to see the salient things, and one obvious thing, if it is present in a patient, you are supposed to describe it. For example, just on the face, you can identify whether the patient is having any signs of chronic renal failure, the sallow complexion, or any signs of the hypothyroidism, any signs of the acromegaly, or if the patient is having an asarcal. So if any of these is present, you may need to mention it in your clinical examination. But if not, need not to mention. But what you need to mention is you have to look into the eyes, look for the pallor, look for the jaundice, and look for the cyanosis. Now what is pallor? The pallor is you avert the lower eyelid, and look at the color of the conjunctiva. If it is pink, you will say the pallor is absent. But if it is less pink compared to the usual findings, then you will say that the pallor is present. It is less pink, it is not pale. Then this is when the hemoglobin is low. The converse can be there. Patient might be having polycythemia. It may be secondary, primary, whatever it is. But in that case, the conjunctiva will look more pink, and there will be slightly reddish color over the cheeks as well. So this look is called plethoric look. After the conjunctiva, you go to the sclera. You hold the upper eyelids and you ask the patient to look down, niche dekh, and you see the sclera on the both sides. In the past, people used to say, look for the jaundice in the sunlight, because in those days the white light was not available. It was the bulb light which was yellow in color. But now when the white light or the fluorescent light is present and it is sufficient, then you can demonstrate the jaundice even in this light as well. There are people and there are books which have mentioned to look for the jaundice over the palate. I don't think I can find it over the palate. To look for the jaundice over the elastic fibers, and the white elastic fibers are present in the sclera, and that is the most important site where you can look for the jaundice. When it is very severe, it may be obvious even on the skin as well. After the jaundice, you go to the oral cavity. You ask the patient to show the tongue, zuban bahar nikala, and look at the color. Now this color, if it is pink, you will say that the patient is not having cyanosis. But if the color of the tongue is purple or bluish, then you will say that the patient is having central cyanosis. Along with that, you can look into the oral cavity for the oral hygiene or any presence of the thrush in the oral cavity or the staining of the tongue as well. So these are the three important things which you see over the face. Next, there are three important things in the neck. One is the lymph nodes, second the thyroid, and third the JVP. These are the three things which you have to look while you are examining the neck. For the thyroid, you need to see the patient from the front. If there is no obvious swelling in front of the neck, you ask the patient to swallow. If it is a small, you can say, or a minimal enlargement of the gland, that will be very obvious. Thuk niklo, thuk niklo. So, if there is swelling which moves with the protrusion of the tongue, this will be a thyroglossal cyst. But if it moves with the deglutition, it will be the swelling of the thyroid. Then if you have to palpate the thyroid, you have to go to the back of the patient and you palpate it from the back side. Then what is the normal size of the thyroid? It is said usually it is the distal phalanx of the patient's thumb. So his thyroid will be approximately of this size. Now to see the JVP, first of all is the site of the JVP, and that is on the right side. You join these 2 points, one over the angle of the mandible and the second between the 2 heads of the sternocleidomastoid, and this line will give you the surface marking of the right internal jugular vein. The left is not like this, that obliquely crosses the neurovascular bundle and it comes down. Now at this side, what do you want to see? The pulsations which you see in this area, they can be arterial or venous. The arterial pulsations, they have got a single upstroke like this, while the venous pulsations, they have the double upstroke and the double downstroke like this. Venous pulsations, they have definite upper limit, and this upper limit increases or decreases, it changes. The upper limit of the JVP changes with the position of the patient and with the respiration. If you make the patient upright, the level of the JVP will go down. If the patient takes a deep breath in inspiration, this will go down. Then you cannot palpate the venous pulsations, and as an undergraduate, it's sufficient to say that the venous pulsations are not palpable. But as a postgraduate, the statement will be the venous pulsations are not usually palpable except in severe tricuspid regurgitation. And lastly, if you apply pressure over the base of the neck, the venous pulsations will disappear. So this is what you see. Then what is the proper angle to see the JVP? The proper angle to see the JVP usually is described 45 degrees. but as a postgraduate, your statement should be the best angle is at which the upper limit of the JVP is visible. That may be 45, 60 or even 90. Now, if you have seen the upper limit of the JVP, then how do you measure it? To measure the JVP, you need the two pencils. The one should be placed. To measure the JVP, you need two pencils and you place one pencil at the sternal angle vertical to the ground, not vertical to the patient. It should be vertical to the ground and it should remain vertical whatever the position of the patient is. Another pencil at right angle to the first one, but its upper limit should touch the upper limit of the JVP. And what you have to measure is, you have to measure the vertical distance of first pencil like this. And this will be measured in centimeters and stated as the 3 or 4 centimeters of water or blood. And if somebody asks what is the total JVP, you need to add 5 centimeters to this reading because the tricuspid valve is 5 centimeter deep to the angle of Lewis. That will be the total JVP. Now when you have demonstrated the upper limit and measured it, there is a waveform in the JVP. Outward movements and the inward movements. The outward waves are the A, C and the V wave. The C wave is not visible. The A and C can be seen. Now how do you identify the A and the C wave? The A wave, for the A wave, you place the thumb over the carotid artery and you look for the outward movement of the JVP. The outward movement which coincides with the carotid artery, that is A wave. One which does not coincide with the carotid artery will be V wave. For the X and Y descents, you place the stat over the base of the heart and you listen to the first and the second heart sound. Any downward movement in the neck waves which coincides with the first heart sound is the X descent, and one which coincides with the second heart sound is the Y descent. Now there might be a patient in which the JVP is so raised that even in the sitting position, the upper limit of the JVP is not visible. For that, you ask the patient to sit and extend the arm and look at the veins of the hand. These veins will be engorged with the blood, and when you ask the patient to gradually lift the arm upwards, at some point these veins will become empty. So at a point where these veins become empty, from there you take the vertical distance above the angle of Lewis, and that will be the total JVP of that person. After the JVP, we go for the lymph nodes. Now, lymph nodes in the neck, in the axilla and in the guinar region, they are palpated. These are the 3 groups. In the neck, we have 7 groups of the lymph nodes, and these are palpated from the back side. Head is slightly flexed and you place your fingers below the mandible and you roll the skin to feel the submental group of the lymph nodes. Then you roll the skin over the submandibular group of the lymph nodes, then the preauricular group of the lymph nodes, then the postauricular. For the occipital, you can use the thumbs, and then the anterior deep cervical and the posterior deep cervical group of the lymph nodes. You roll the skin and you try to find the lymph node. For the scalene group of the lymph node, you place your finger between the 2 heads of the sternocleidomastoid, push it down deep into the thoracic cavity, and then feel subclavian lymph node. So, what is the normal size of the cervical lymph nodes? Their normal size is less than 5 millimeters. Then the axillary lymph nodes, their normal size is less than 10 millimeters, and the inguinal lymph nodes, they are less than 20 millimeters. So axillary and the inguinal, they can be palpable in patients. Now, how do you feel the axillary lymph nodes? First of all, if I am standing on the back side, one can feel the posterior group first. For the posterior group, you push your hand into the axilla, press it against the posterior wall of the axilla, and thumb on the back side, and then move your fingers downwards deep into the axilla, and if there are posterior group of the lymph nodes, they will roll under your skin. Then rest of the lymph nodes, they are palpated when the patient is in the lying position. To feel the axillary lymph nodes, the rest of the four groups, the medial, apical, anterior and lateral. How do you palpate it? Now, to feel the medial and the apical group on the right side, slightly flex your fingers so that they take the shape of the chest, which is curved like this. Push your fingers into the axilla, press it against the chest wall and bring them down, rolling the skin against the thoracic cavity. Similarly, on the other side, the other hand, and move it down and feel under the skin. If any of the lymph nodes slips, that should be observed. For the anterior group, you push your hand like this into the axilla, press it, the thumb on the front, and then roll the skin and feel it. For lateral group, you need to change your hand, push it into the axilla, press it against the humerus and roll the skin downwards, or feel it over the lateral part. For the lateral group, you need to push your fingers into the axilla and press it against the humerus and then roll your fingers downwards and feel if the lymph node slips under your fingers or not. So this is how you feel the axillary lymph node. Over the chest, you look for the spider nevi. They are in the shape of a spider in which there is a central small arteriole, and from that are the radiating capillaries. And how do you identify them? If you press the central arteriole, the radiating capillaries, they will disappear. Then you need to see the hair distribution in the axillae and the pubic hairs, and in the male, look for the gynecomastia. Gynecomastia there are 2 points in the life where it's a physiological one. One is the infants, and second at the time of the puberty in the males. Now, how do you look for the gynecomastia? You hold the skin around the areola like this and press it. If the disc under the areola is palpable, then this will be called gynecomastia. Over the abdomen, you can have the prominent abdominal veins, and then you go down and over the feet. To demonstrate the ankle edema, the site is, this is the medial malleolus. In the center of the medial malleolus, you press with your thumb, hold the pressure for a few seconds, and then you look for a pit, if it is visible or palpable over there or not. If it is not palpable, then you will say that the ankle edema is not present. And if the patient is bedridden, then look for the sacral edema. You press over the sacrum and you look for the sacral edema. Thank you very much.